Thank you, Kate. What I'd like to do first is to poll our audience by asking them to select which of the categories shown on the screen best describes their current professional role. I am not seeing the poll results.
We're sorry about that, Ginger. We're showing 54% in community corrections, 29% as researchers and consultants, and 10% in local and county facilities.
Oh, good. Thank you. Now I'd like to set up the context for our discussion today, which, as you know, is about effective clinical practices in treating clients in the criminal justice system. And the first thing I think that we need to do is to acknowledge that the goals in the criminal justice system may be different than the goals in the treatment system. And then that's part of the context in which we will work. The overarching goal for the criminal justice system is to control criminal behavior in those who come into the system today and to reduce the risk of criminal behavior in those same people in the future. In other words, we're very concerned about reducing recidivism. Whereas in the treatment field, generally the goal is to address the individual's particular problem that they present with when they come into the treatment agency. When we're trying to put together a treatment in the criminal justice system, then we need to take into account the goals from both systems to respect both goals, and both of those goals count. So success then is measured both in problem resolution, like reducing domestic violence incidences or substance abuse or impulsivity, for example, and also in reducing recidivism. And because we're working on really looking at both of those goals, we need to draw knowledge from both the treatment field and the corrections field. Fortunately, evidence-based practices generally complement each other in treatment in criminal justice because we're really looking at the factors that contribute to human change, and there tend to be some commonalities in those factors. For example, cognitive behavioral approaches work well in reducing the risk of future criminal behavior. As we modify criminal thinking, we help people learn coping skills such as self-control and problem solving. The treatment literature very often also promotes cognitive behavioral approaches and effectiveness. That's true in substance abuse treatment and sex offender treatment. We know that social learning theory, for example, works well with offenders, in which we're applying positive and negative consequences, teaching new skills, practicing, giving feedback. Again, we find social learning theory is an effective approach in the treatment field as well. Other examples, relapse prevention skills, continuing care after intensive treatment. The other thing that I think we need to acknowledge when we're trying to figure out how treatment fits within the criminal justice system is we need to acknowledge that there are multiple clients. There is, of course, the individual offender client. We need to attend to individuals, their goals, their needs. We don't engage them in treatment unless we do that. On the other hand, in the criminal justice system, there's really no reason to include treatment if it doesn't address the corrections goals. So the corrections system and its goal to reduce recidivism is, in a sense, a client of the treatment system. And finally, in this case, the community is a client also. We have some responsibility for the safety of the community in the correction system, and the community certainly has a stake in the outcome of treatment and whether or not these individuals will continue to perpetrate crimes. So moving to the next slide, and just quickly, what do we know about reducing recidivism? Well, we know that if we apply punishment alone, we are not likely to reduce future criminal behavior. But we do know that treatment designed for offenders does work to do this. And in fact, I believe that really corrections agencies can't carry out their missions to reduce future criminal behavior without including correctional treatment in their overall approach. Next slide. I think most of of the audience is probably familiar with the principles of evidence-based practices, risk, need, and responsivity, which essentially tell us who we should pay attention to, those higher risk individuals, what we should pay attention to, that is the criminal risk factors that people bring in as we begin to work with them, and finally how we should address those risk factors, and that tells us how to design treatment in ways that work best for most offenders. I wanted to give some examples of how we apply those principles from the research in corrections practice in Oregon. The first screen, the screen that you're looking at now, is information in our management information system that tells us by jurisdiction in this case what percentage of high and medium risk offenders are currently engaged in various kinds of treatment. And it also gives us the percentage and the number of overall offenders from that jurisdiction. And what we can tell from this then is how many lower risk offenders are we sending to treatment. If you don't see the numbers matching up, and you won't in any county, I don't think, we're not at 100% certainly. So that means we are, in each jurisdiction, we are sending sometimes many offenders, sometimes not very many offenders who are lower risk. We're sending them to treatment anyway. So that helps us know how well we're targeting our treatment resources to those higher risk people, and can bring up questions then where we see some big gaps there. The next slide is some data from the LSCMI. This is the tool that we use to tell us what to target. So here you'll see this is data from the statewide data reflecting our medium and high risk population and those particular risk factors that the LSCMI is picking up and that are rated high or very high. What this information tells us then is what types of programs and interventions do we need to be including in our overall approach. And this is not just necessarily treatment programs. The probation parole officer is a part of the intervention approach. For example, we should be seeing recreation leisure, criminal associates, employment and education deficits, drug treatment needs in the correctional case plan. There's no reason that a probation parole officer can't be addressing recreation and leisure. Criminal associates are two highest rated domains in their interactions daily with offenders. So this information should be guiding what we see in our case plans. It should be guiding us in terms of what kinds of treatment programs we want to incorporate in our approach. And it should be helping the treatment programs themselves design targets for intervention. So, for example, a substance abuse treatment program can and should incorporate more than that one criminal risk factor. They should be looking, again, if we're using our data, at leisure recreation, at building pro-social support in the community, and so on. And then moving on to how. So we've talked about who and what. When we are looking at how we deliver treatment in our system here in Oregon, we have been using the Corrections Program Checklist, which helps us know which programs are actually designed and delivered closest to what the research says. And this is real data from some of our initial reviews of community programs, showing that about just a little bit over half of our programs were rated satisfactory on this particular tool, and a smaller percentage were rated unsatisfactory. Where we have rated a program unsatisfactory, they get very specific suggestions in the actual CPC document about what they might do to improve their programming. And in general, we find when we go back and do a re-review that those programs have been able to bring themselves into the satisfactory range. So the process seems to be doing what we had hoped it would do, which is to actually improve the design and delivery of our existing correctional programs. One of the ongoing challenges, and this is the next slide, thanks. One of the ongoing challenges as we seek to incorporate treatment into the criminal justice system is the need to collaborate. Regardless of the type of treatment, we have to work collaboratively to have the greatest impact. Ideally, the treatment professional and the corrections professional are coordinating their case plans and their expectations so that one, each professional can support the other, and two, we aren't giving inconsistent expectations to people that we're working with. The most common one I think that comes up is which is more important for this person, work or treatment, when the schedules conflict. Again, ideally, both systems have the capacity of providing both positive incentives and sanctions for inappropriate behavior, so the correction system and the treatment system should work together to decide which system will respond to what kinds of problem behavior or noncompliance. And the last point I want to make has to do with how we handle problems generally when we're sending offenders to treatment. As we get better and better at sending the highest need and the highest risk individuals into treatment, that means we are sending people who very much, one, need treatment, and two, are not good at following rules. And so it's important that we don't remove offenders from treatment for having the problems that we're sending them for. So if it's a substance abuse problem, plan to handle a lapse into drug and alcohol use, plan to handle noncompliance with the rules in such a way that we are responding to the behavior, because that's part of a social learning approach, but we are responding in a way that continues to keep that person engaged in the treatment experience. My last point that I want to make before we get to questions is if we're going to have evidence-based practices, we need to have evidence. And that means we need to know if clients in the program, are they changing? So we might want to include some kind of pre-post testing or analysis testing, some way to capture that change if it's occurring or not occurring. Secondly, we need to know if the program itself is working. So, for example, if we're sending people who perhaps aren't terribly motivated, we want to measure retention and engagement. Is the program skilled at keeping people, getting people engaged in the treatment experience? Can we measure the change in the targeted criminal risk factors in the short term, and is that program lowering recidivism compared to similar untreated groups in the long term? And then we must never assume that the program is operating as designed, and we need to have some way of testing the fidelity of the program to the model. So before we get to our panelist discussion, which is where we're ready to move now, we wanted to poll the audience again on whether you are currently utilizing effective clinical practices in treating your criminal justice clients. And while you're selecting your responses, we want to remind you again that at any time during the webinar, you can submit questions to our panelists through the questions box on your screen. Okay, I can see these poll results, and I'm seeing that 70% of you are currently utilizing effective clinical practices in treating criminal justice clients.